Hey guys, Dr. Linville here. We're going to be going over the kinesiology of the elbow and forearm. So thank you for tuning in. And just a reminder, we want you to read Levangie and Norkin on this material. Also, one of the best ways to study, for my lectures at least, is that as you go along, I want you to pause. If you're kind of confused about something I'm saying, pause the slide, pause the video, try to look up at that moment, write down some questions you might have, and kind of go from there. I think that's kind of what students have told me is the easiest way to do it. So just a little pro tip, hopefully, for you there. So objectives of this are to understand the articulations of the elbow and forearm and their purpose and rehab interventions and manual therapy techniques, review anatomy of the elbow and forearm and their relevance to kinesiology, understand the osteo and arthrokinematics of the elbow and forearm, and learn about common musculoskeletal injuries in the elbow-forearm complex. So as an introduction here, the elbow is an innately stable joint. It's thought of as a hinge joint. However, there are three joint articulations within the elbow complex. An important concept to really learn here is that the joints and muscles of the elbow complex are not really meant to serve the elbow. They're meant to serve the hand. So when we get into the hand section on Thursday this coming week, you'll understand and realize why that is. So just an anatomy review here, the elbow and forearm complex is comprised actually of four joints. We're talking here about the Humerorulnar joint, which is the what someone would think of as a true elbow joint, the hinge of the elbow joint. And you have the Humeroradial joint, the proximal radial ulnar joint, and the distal radial ulnar joint. Now the distal radial ulnar joint, or we call it the DRUJ, that is going to be discussed more probably with Brian Tees, who's an occupational therapist, during the hand lecture on Thursday. So here are just some pictures that I'd like you guys to pause and take a look at. It's pictures of the anatomy of the humerus, and one thing to really take a look of is the inferior view of the humerus, where you can see the capitulum, the trochlea, the trochlear groove, all these different areas that are important for joint articulation and will be important for you to understand and realize as we go on through this lecture. Here is what we can see as the radial ulnar joint, right, or the radius and ulna, and anatomical structures that are involved here. So again, pause it. I want you guys to take note of, in particular, the interosseous membrane, kind of how the fiber orientation is designed there. And then finally, we have looking more at the proximal ulna, and what I really want you guys to look at here is the trochlear notch and just how concave that surface is. It's probably the most concave joint in the body, and it's comprised of approximately 200 degrees of concavity, which makes it very, very stable as it articulates with the trochlear groove of the trochlea. So that's why the elbow, bony-wise, is so stable. So let's jump into the articulating surfaces of the elbow joint. So the articulating surface of the humerus, you have the trochlea, which is hourglass shaped and articulates with the ulna. We just mentioned this. You also have of the humerus the capitulum, which some people call the capitellum. It's spherically shaped and articulates with the radius. So this is almost ball shaped. If you think of like the head of your humerus, the capitulum kind of has that same sort of spherical quality. If you look now at the articulating surface of the radius and the ulna has the trochlear notch, which is a deep semicircular concave surface, as we just went over a couple seconds ago. The ulnar portion of the humerorulnar joint and articulates with the trochlea of the humerus. The radius, the articulating surface, is the head of the radius. It is cup-shaped as a concave surface known as the fovea. So if you go back a couple slides and you look at the anatomy of the radius and the ulna, you'll see that there's an indentation in the top of the radial head called the fovea. That's what articulates with the capitellum or the capitulum and creates kind of this pseudo ball and socket joint, which allows for flexion, extension, and then rotation along the long axis of the radius. So you guys should be able to understand the articulating surface of the humerorulnar and humeroradial joints. So as we continue here, the humerorulnar joint is primarily what's occurring here is a sliding motion. the ulnar trochlear ridge on the humeral trochlear groove. So in full extension, motion is stopped as the olecranon process of the ulna enters the blank of the humerus. I want you guys to kind of critically think about this, and then there's a lot of blanks in this lecture where I'll have you guys actively participate, and if you have questions, we can answer them in class. So just to kind of reiterate here, we're going to look at full extension, full flexion of what's happening at the humeral ulnar joint. So in full extension, motion is stopped bony-wise as the olecranon process of the ulna enters the blank of the humerus. And then in full flexion, motion is stopped as the trochlear ridge slides along the trochlear groove until the blank reaches the coronoid fossa of the humerus. Moving on to the humeroradial joint. So we have the capitulum of the humerus, which is convex, articulates with the radial head of the radius, which is concave. So in full extension of the elbow, there's actually no contact between the joint surfaces. This is what we call open packed position of the humeroradial joint. And then in full flexion, the rim of the radial head slides in the capitulotrochlear groove and enters the radial fossa. You can see that in the picture over there on the right, as the end of the flexion range is reached. So it kind of sits there, and then you have bony contact, and you have a hard end feel. You just can't go any further. So articulation of the radial ulnar joints. For our intents and purposes today, let's just look at the top bullet there, which is the proximal radial ulnar joint. The radial notch of the ulna is concave and articulates with the head of the radius, which is convex. It's surrounded by the annular ligament. So if you follow my mouse here, here's the annular ligament, which encompasses that joint, and the joint sort of looks like this, right? So the ulna is concave, the radius, or radial head, is convex. That's an important concept to realize as we talk about joint arthrokinematics and how you would help someone improve, say, pronation or supination, what glides you would do. And it gets a little confusing because it seems backwards. We'll go over that near the end of this lecture. The other thing I want you to realize here is the humeroradial joint. As you can see here, remember I talked about that pseudo ball and socket joint? So this, because of the attachments to the annular ligament and fascia and that sort of thing, does not allow the radius to abduct and adduct. But what it does allow is for long axis rotation there, kind of like you would turn a doorknob, and that allows for pronation, supination of the forearm. So I just wanted to give you guys a visual there. The joint capsule of the elbow, all of the elbow joints are encased by one single joint capsule. It is fairly large, loose, and weak anteriorly and posteriorly, but that means it's very taut and strong medial and laterally, and that's because it's reinforced by the medial and lateral collateral ligaments. As we go into the ligaments of the elbow here, let's just talk that most hinge joints in the body have collateral ligaments. So we're talking things, all the way from your knee to your elbow to even some of the digits of the finger. They all have collateral ligaments that support and create hinge joints. So the ligaments of the elbow here are the medial or ulnar collateral ligament, the lateral or radial collateral ligament complex, and then the annular ligament. So we will dive deeper into these. From now on, we will refer to the medial collateral ligament as the UCL, and that's kind of what all the research is now calling it because of the high incidence now of Tommy John surgery and UCL injuries. So let's just keep that in mind. Tommy John surgery, I'll have you guys look that up if you don't know what that is. The primary role of the UCL is to restrict blank motion at the elbow. Here we're getting to some of our blanks again for you guys to actively participate, and consists of three parts referred to as bundles. The 1, 2, and the third would be the transverse bundle. And just to give you a way to visualize this, why don't you just look at the picture on the right and you'll figure out what the answers to those are. Mechanoreceptors or proprioceptors are densely packed within this ligament, and those are the names there on that second bullet of the type of mechanoreceptors that are present. And then finally, this is probably the most important bullet to understand on this slide. for understanding what bundle of the UCL is the primary ligamentous restraint against valgus stress during throwing, right? Because this bundle resists valgus stress when the elbow is flexed between 20 to 120 degrees, which, if you think about someone throwing a ball, is the amount of elbow flexion that's present as your arm is accelerating forward, putting valgus stress on the elbow. So this is primary bundle that's repaired or reconstructed during Tommy John surgery. Here's just a close-up picture of that complex there. So functional summary for the UCL: it stabilizes against blank torques at the medial elbow. It limits extension at the end of the elbow extension range of motion. It guides the joint motion throughout flexion range of motion and provides some resistance to longitudinal distraction of the joint surfaces. Right, so some of these you'll see also for our functional summary of the LCL complex, and that's because both of them, they're on either side of the elbow. So, in regards to, say, number 4 here, where it provides some resistance to longitudinal distraction of the joint surfaces, if the elbow is getting put on traction or getting pulled, both the UCL and the LCL will combine to try to limit elbow traction or distraction. So now let's get into the lateral collateral ligament complex. And the reason it's called the complex is because it's made up of 3 different ligaments. That would be the lateral collateral ligament itself, the lateral ulnar collateral ligament, and the annular ligament. So the primary role of these these ligaments collectively are to restrict blank force of the elbow and also to maintain posterolateral stability. So the reason we put that posterolateral stability point in there is because the annular ligament, which holds the proximal radial ulnar joint in place and provides stability there, if that's torn, then you have a very high risk of dislocating the radius from the ulna, and typically the direction of instability or direction of fracture and things like that is going to be posterior and lateral just because of anatomy. And essentially what happens is that annular ligament tears and the head of the radius slides right off the capitellum and dislocates posteriorly. Then you got bad news. So this complex is fan-shaped in nature and extends from the lateral epicondyle of the humerus and blends with the annular ligament of the radial head. As we mentioned, the annular ligament encapsulates the radial head and creates stability at that joint. Here's just a closer-up picture of the lateral aspect of the elbow. Functional summary for the LCL. LCL complex, right, stabilizes against blank torques, stabilizes against combined varus and supination torques, reinforces humeroradial joint and helps provide some resistance to longitudinal distraction of the articulating surfaces. It stabilizes the radial head, thus providing a stable base for rotation. It maintains posterolateral rotary stability, prevents subluxation of the humerulnar joint by securing the ulna to the humerus, and finally prevents the forearm from rotating off the humerus and valgus and supination during flexion from the fully extended position. So maybe not technically a ligament, I guess actually technically it is a ligament, but we just put a little more emphasis on this because it's so broad and strong, is the interosseous membrane. It's taut connective tissue located between the radius and the ulna. During rotation, the interosseous membrane prevents the radius and ulna from splaying apart. Right, so this keeps the bones approximated together. It protects the proximal radial ulnar joint by transferring some of the compressive loads at the distal radius to the proximal ulna. So we have a slide on this specifically, but you can see the distal radius, we call it the base of the radius. The hand is connected to that, right? So if there's pressure, like through a foosh, a fall on the outstretched hand, the force is going to run up through the thicker bone, which would be the base of the radius, and then the force gets attenuated through the interosseous membrane, transferred to the ulna, because that starts turning into the bigger and thicker bone as you move more proximally, and get the energy and force gets transferred through the, I guess you would call it the base of the ulna, where the trochlea is. So we have a slide on it. We'll go over it then too, but just know that that helps with force attenuation with like a Fuchs injury. And then finally, the interosseous membrane maintains transverse stability of the forearm during compressive load transfer from the hand to the elbow. Actually, we just kind of talked about that. Here's that slide. What great timing. So someone lands on their arm. They have compression force. You can see that going up through the palm of the hand there. You can see that the red arrows kind of show you the force that's being transmitted. So of course there's going to be some force going through the distal ulna, but mainly that force is going to be going through the distal radius, the base of the radius. It goes up, and you can see from number 1 to number 2, and then the force gets attenuated over the interosseous membrane, which are those two black arrows showing 2 to 3, and then 3 to 4 and 4 to 5, and you can see how the force get put up. Now, obviously, there's going to be some force that's put through the proximal end of the radius, through the distal end of the humerus, but the interosseous membrane serves to try to decrease that compressive load, because the radial head is an area that can get fractured very easily, especially in older people. So we'll just keep that in mind as we go forward. So here's another slide that you can pause. It's the muscles of the elbow and the forearm. I'm not gonna sit here and read all these to you, but good to know. Here's just a visual of where those are at, and then your anatomy class, you should be going over these, if not soon, then, well, I don't know what to tell you. If not soon, you need to review these for this lecture at least. And then when you get to it in anatomy, you'll be much more prepared. So one of the things that's important about the joint articulation here is what we call the axis of motion. So if you look at the X-ray or the radiograph that's pictured on the right, you can see that it's drawing a line through the ulna. And that line kind of extends into infinity, right? That would be what we call the axis of motion. But you can see that the humerus is actually not articulated in that same exact plane, right? There's this little angle or angulation that occurs at the elbow, which we call like a valgus angulation. The reason that is because the distal segment of the humerus, actually the medial side of the distal humerus extends further than the lateral side of the distal humerus. We call this a lateral angulation. And that angulation is between 4 and 8 degrees, and it's what gives people their carrying angle. If you've read the book, here we'll go over in a slide or two here, carrying angle is an important thing to understand, because it helps you in rehab through how you're going to help the person with maybe manual therapy or giving them exercise interventions. So you can see the angulation there. It's important to realize. Also, the axis of forearm motions does not occur through the center of those two bones. There's actually an oblique angle axis of rotation. I'll show you that in class. We can demonstrate that. It goes from the radial head through the ulnar head, and those bones kind of spin around that axis. And if you just do it on yourself here, you can notice that axis in play. So try going through forearm pronation and supination. You can see that those bones don't spin, and keep their anatomical relationship. They actually kind of cross over, like you're crossing a pair of strings or something like that. It's kind of a weird analogy, but if you cross your fingers, kind of gets that same idea of what the bones are doing when you go into pronation and supination. So the carrying angle, the medial aspect of the trochlea extends more distally than does the lateral aspect, which creates this slight lateral deviation from the midline. The axis of motion is superior and lateral. This is called the cubital valgus, also known as the carrying angle. Normal carrying angle is 8 to 15 degrees. Males have a little less, on average 5 to 10 degrees, and women have a little more, 10 to 15 degrees. Here is several pictures of different types of carrying angles. These are all what we would consider, or at least A through C, we would consider these probably anatomically normal, just different anatomical variations because of genetics and so and that sort of thing. But the gun stock deformity on the very last picture is usually due to some sort of actual bony deformity. So you can see normal carrying angle on the very left. If you have excessive cubital valgus, we would just call this, that you have a high carrying angle. And then cubital varus would be anything from 0 degrees to -5 degrees. And then a gun stock deformity is, a hyperangulation inward. And the reason they call it gun stock deformity is because, if you think about like a cowboy in the Wild West, he's always ready to pull his gun out from his holster on his side. And that's kind of the position the arm looks like it's in at all times. So cubitus varus refers to the medial angulation of the elbow and is considered abnormal. Carrying angle disappears when the forearm is pronated and the elbow is in full extension and full elbow flexion. So if you do that for me for a second, if you go into full elbow extension, you have a carrying angle in that position, but if you pronate, that carrying angle disappears. Same thing when you're in elbow flexion. The carrying angle disappears because your axis is, we talked about that oblique axis before. That's kind of the reason for that. And then during elbow flexion, carrying angle disappears around that 30-degree mark. So now we'll get into the good stuff. Osteokinematics. You have normal range of motion for the elbow here. It goes anywhere from 10 degrees of hyperextension all the way to 150 degrees of flexion. You can see the ranges of what we would consider normal. That means the total arc of motion of the elbow, or the humeral ulnar joint, we'll call it, right, elbow flexion, is 160 degrees. 10 degrees of hyperextension to 150 degrees of elbow flexion. Then we look at forearm supination, forearm pronation. You'll see maybe different numbers here. Some people believe it's up to 90 degrees in supination, pronation, but really I think the standard here is you get a little more supination, 85 degrees, and then you do pronation about 70 degrees. So, roughly 150 degrees of total arc of motion here. And now the arthrokinematics. So if let's just start on the picture on the very left. Those pictures of the elbow in full extension and the elbow in full flexion. So the reason I really like this picture is you can see on picture B on the left how they describe the roll and glide. And the concave, convex roll. This would be the concave roll. The ulna's moving on the humerus, so it would roll and glide in the same direction. Same thing when it goes into extension. It will roll and glide in the same direction posteriorly. So now looking at letter A for that picture on the left, I want you guys to understand here, so we're looking at the medial side of the elbow in full extension. You can see those straight lines. Those are representing the dermis or the skin, the fascia, the muscles, the forearm and elbow flexors, and the anterior capsule. Also looking at the MCL. All those are very taut in full extension. Those just reinforce that the elbow stability while you're in elbow extension. Likewise, the extensors in the posterior capsule you can see are very loose and lax. And then the same thing happens but in reverse when the elbow goes into flexion. The posterior capsule, the extensors, the skin, the fascia, the MCL, the LCL, they're all very tight or taut during flexion. And then the flexors in the anterior capsule are loose during flexion. The one big thing I want you to point out here, though, during flexion, you can see that they've made point to put in the ulnar nerve. So as you go more into elbow flexion, the ulnar nerve gets put more on tension. And that's just important to realize as you go through your career. If people start having ulnar nerve type symptoms, the elbow position matters because you can see it has to make this kind of right turn, 90-degree turn at the elbow's flexed, and gets put on stretch. Now I'm talking about arthrokinematics here of the other joints. And if we start at this picture, here we've already kind of mentioned, right? So concave on convex surfaces, both the proximal radius and the proximal ulna are both concave, so the same rule applies. So elbow flexion extension, roll and glide is going to be in the same direction. Where things get a little tricky is the proximal radial ulnar joint. This is looking, straight down through the joint. You have your radial head here and your ulna here. So you can see the concave ulna, which is the radial notch, and how the radial head is convex and sits in the radial notch. So for forearm pronation, what's occurring here is you're getting an anterior roll and a posterior glide. Okay, so go over that again. Concave ulna, convex radius. When you are going into pronation, you're getting an anterior roll and posterior glide. You have to think here anatomical position, right? Likewise, and opposite, forearm supination, you get an anterior glide and a posterior roll. Anterior glide, posterior roll. So I want you guys to think about if you wanted to improve someone's forearm pronation by using joint mobilizations at the proximal radial ulnar joint, what direction would you glide the radius in? Okay, so that's a good test question. So rules to apply for joint mobilization. Here's the open and closed pack positions. I'm not going to sit here and say these all to you. You can read them, write them down, memorize them, but understand them, right? So if it says that a closed pack position is full extension and full supination, try to understand why that's the closed pack position. We know that open pack position, the joint is at its most lax point. Closed pack position, the joint is at its most taut or stable point. So try to understand why these are the open and closed pack positions, and then the degrees are going to just kind of fall into place. But where it gets a little tricky is down here at the proximal and radial ulnar joints, how open packs 10 degrees, closed packs 5 degrees. I mean, really hard to distinguish that in real life, but the anatomists have determined that's what open and closed pack positions are. So just try to remember these. And remember your concave and convex rules. So for humeral ulnar joint mobilization, we will do this in lab today, or rather in class. The patient is positioned supine, elbow is in the open pack position, which you can tell is that it's 70 degrees flexion. If you go back in the one slide, you'll see what open pack position is. The PT is the person obviously in the like blue-purple shirt there, seated with hands interlocked around the antecubital fossa and the proximal forearm. We're going to talk about the scoop method and distraction of the elbow joint here. These are both to improve elbow flexion. And then the humeroradial joint, if we think back to that slide where we talked about open pack position of the humeroradial joint, you can see that patient is positioned appropriately. Full elbow extension with full supination. Anterior glide improves what motion here, and posterior glide improves what motion here. And I want you to think both glides that are for the humeroradial joint and the proximal radial ulnar joint. Okay, so try to fill that in the blanks. And then finally, our last little section here is examples of common injuries of the elbow. So traumatically speaking, we have a UCL sprain, we have an elbow dislocation, which is also known as posterolateral rotary instability. You can have a distal biceps tendon rupture, and of course, you can have fractures. And then, probably the most common injuries here of the elbow are overuse injuries. So we're talking lateral and medial epicondylalgia. Used to be called epicondylitis, so that's your tennis and golfer's elbow diagnoses. You can have distal biceps tendinosis, or chronic inflammation of the distal biceps tendon. You have little league elbow, which is basically a UCL sprain, or it's actually apophysitis, right? Growth plate injury and irritation in youth athletes, and then UCL sprains in throwers. So traumatic dislocations, I should have warned you, right? So you have all these players who have one common thing one common theme. They've landed with a force going through their hand, Fouche type injury, but their arms positioned in supination and valgus, right? So Amendola probably went to catch a ball, was stumbling, put his arm down, and his arm was in that perfect position. Supinated forearm, valgus position of force, and you get a posterolateral instability where the elbow dislocates. Same thing with Rajan Rondo. And I think the soccer player just kind of had an unfortunate event where he was getting slide tackled at the same time or fighting for that ball. His arm was probably down like the guy behind him, but that guy behind him just jams his knee into the guy's elbow and creates this valgus stress. Probably a fracture that occurs there too. And then we're talking about this weightlifter here. So, that is probably going through the snatch there, Rich, if you guys know anything about Olympic weightlifting. So let's see, that's 150. It's around 200 kilos. So, yeah, I think that's pretty heavy. I'm not even going to guess how heavy that is. So, yeah, that guy's elbow just dislocated too much. And hopefully he doesn't have a spinal cord injury. And then one thing in youth that I want you guys to understand is what we call nursemaid's elbow. And this is a radial head dislocation due to traction of the radius. So if anybody has kids here, try not to pull on their arm. Or if you do, just grab them by the back of the neck. That seems to maybe work a little better and a little less injury. So medial elbow pain in throwers, we'll talk a lot as we go through our course here, especially in the upper extremity section next term on medial elbow pain in throwers. But one thing I just want you to realize here is youth athletes, in the day and age now of playing for 3 teams and pitching every day and all this stuff, we can have injuries to the growth plates of kids, and this is called apophysitis, right? Because epiphysis is the growth plate, and apophysitis would be irritation or inflammation of the growth plate. And just a very, very common thing that's happening these days. But there's several different growth plates at the elbow. They're the blue in the picture, and those can either get attacked by compressive forces or tensile forces, as the picture shows. Then a radial head fracture. So this is like a Fouche injury. If the distal radius doesn't fracture, the force may go up and injure and fracture the radial head. There's 3 different types. Type 1 is non-displaced closed fracture. Type 2 is going to be a displaced fracture, and then type 3 is a comminuted fracture, which is just basically like someone took a shotgun and blew up your radial head. Not a good deal. And usually what happens is the pictures on the bottom there show what they would do surgically to fixate each of those fractures. And the picture on the very bottom right is a radial head arthroplasty or a radial head joint replacement. Not good. This is what we call Monteggia fracture. So this is when you fall on an outstretched arm, or you can get like what we call like a nightstick fracture, where someone hits you, you're blocking someone from hitting you with an object, fractures your ulna, and your radial head dislocates at the same time. So not good. And then finally a coronoid fracture. And this might happen if you fall into a position of extreme flexion and chip off the coronoid process, which is the proximal lip of the ulna. And then Olecranon fracture usually occurs when someone falls on the tip of their elbow, fixated through screws and plates. So thank you guys so much for your attention. Again, go back, review this as many times as you want, pause it, and thank you.